I just want to welcome you to the Comprehensive Prevention Planning Learning Series. This series can be, I would say, the best place to find all of the different trainings that have already occurred or are to occur would be on our centralized website. You can click that link in the chat box to see all of the different series that have happened, the recordings and resources, along with the registration links for the future sessions to come. And with that, I want to turn it over to our first speaker. We're so excited to have Dana Blackwell, the Senior Director of Strategic Consultation, bringing over 20 years of child welfare and public policy experience. She actually, her role is with Casey Family Programs. In this capacity, Dana leads Casey's work in California, including statewide partnerships, initiatives, and systems improvement activities. So good morning, Dana. I'm excited to pass it on to you.
Thanks, Jess. Good morning, everybody, and welcome to the third form in our learning series, Designing a Comprehensive County Prevention System. This really is the heart of the matter, right? We've been gearing up towards this. It is when you're articulating what you're going to do, identifying your population, what services you will provide, and at what level, and continuing to refine your system so that it functions in a way that is in service to prevention, equity, and inclusion. To that end, we have a great group of panelists that are prepared to share their thinking with you about how to approach your design process. But before I introduce the panel, I want to invite you to not just think about the technical aspect of doing this work, but to also think about what it will take from a collaborative perspective to do this work. It's easy for us to think that this is a child welfare-centric effort. It is not. For example, behavioral health is currently serving parents with substance use disorders. And from that work, they have data and learning about the population that will be important in identifying service assets, gaps, and candidacy characteristics. It will be critical to collaborate with our tribal partners so we understand what community supports and strategies exist and are beneficial. And probation interfaces with many of our population categories, runaway and homeless youth, and families with DV, for example. We each have our hand on a different part of the elephant. Without collaboration, you will not be able to see the whole of what you have or the whole of what you need. Collaboration is a critical component to building a responsive and robust county comprehensive prevention plan. So with that, I'd like to introduce you to our very esteemed panel of presenters. First, Richard Connect, who is the managing partner of Integrated Human Services. Jennifer Rolls-Royce, Director of the California Evidence-Based Clearinghouse for Child Welfare and the California Training Institute. Michael Steele, Senior Policy Analyst, Chapin Hall at the University of Chicago. And Wendy Wigman, Project Director for California Child Welfare Indicators Project. And as per our other two forms, Dr. Kush Cooper, Principal and CEO of Implematics, will moderate our webinar this morning. Thanks, everybody. Kush?
Thank you, Dana. Okay, so we heard you all from based on the feedback from some of the prior webinars that we've held, and we are flashing the topic flow now. So we get that this is a long program. Folks may have certain areas that they're more interested in than others. So we've put the agenda together for you to see. So if you do need to pop in and out, you can do so at times where it's convenient to you and where you wouldn't be missing something that you're particularly interested in. So we'll start off, and I'll do a brief introduction to this domain, the program design domain. We'll I'll turn it over to our first presenter to talk about theory of change and logic models. We'll take a short break, stretch break at about 10:45. Then we'll go back into the presentation and talk about what does it look like to look at your population data to do the needs assessments that are going to be required, so you can decide what services you're going to bring to bear for primary, secondary, and tertiary prevention. Then we'll move to the service side of the equation. And again, looking at it through the lens of primary, secondary, and tertiary prevention, looking at services and gap, and we'll go into a break around 11:45, and then we'll start to put it all together when we talk about a gap analysis, when you look at what you have and compare that to what you need, and you see what the gaps are. So we'll talk about that, and then our final component will be talking about how the integrated core practice model can be integrated into your comprehensive prevention plan. Right? And we aim to close at 1 p.m. on the dot. Right? So what are all the topics we're going to cover today? We're going to cover what it's going to take to understand your local community needs, which, when unmet and heretofore unmet, have been contributing to disproportionality and disparity. We're going to talk about how to map the current services you have at each level of prevention. We'll talk about how one might go about defining appropriate service offerings, both evidence-based practices and other non-EBPs, to meet those community needs that your analysis have shown. And we'll talk about how to leverage and incorporate the tenets of ICPM with prevention. Right? And I'm not going to go through all of the learning objectives, but you have those here for your reference. All right, so we have covered in our last two, and this is our third learning forum, certain domains, which we say are a organizing principle for how you go about writing your plan and then implementing it. So on July 20th, we covered the governance domain. Okay. Also on July 20th, as part of the governance domain, we covered, well, what does it look like to have stakeholder collaboration when you govern and implement a comprehensive prevention system? We talked about fiscal and funding, June 29th, and today, I'm missing a closed paren, we're going to talk about program design and service array. On the 21st of September, we will, I think I have that date right, we will talk about service quality and outcomes. And then in October, we will talk about workforce training and development. Right? The other domains, while they will become important later in implementation, aren't as relevant to the work that's required to complete the comprehensive prevention plan that counties have due January 31, 2023. So we will have forums that cover those in 2023 in more detail. All right. So what are the elements of this domain? Okay. So vision and strategy is one key element. And inside of that, vision statements, theory of change, logic models, and needs assessments. Then a service array is also a component of program design. Talk about evidence-based practices and non-evidence-based practice prevention services. Those are both part of the service arrays that you all are going to have to design. How you're going to do a gap analysis that shows you what you need to bring newly, what you need to expand, what might not be working that you don't want to bring forward into your new prevention system. And then the integrated core practice model and how we use the tenets of that with a prevention lens. Casework is part of program design. So somebody's going to have to deliver these services that you all put in your plans. And staffing models, who's going to do, at the county level, who's going to do candidacy determination, what do caseloads look like, what are the best supervision models to use, case management protocols and best practices, how you're going to monitor safety and risk. And if you're electing to do a community pathway, how are you going to bring community-based providers, service providers, into the staffing fold? So how services are going to get delivered and who's going to deliver them will be covered in a later forum on workforce development. Right. So if I were evaluating whether you, from a program design perspective, were ready to implement prevention services, here's what I'd be looking for. I'd be looking to see if you have a documented and approved by your governance body vision, which would look like a vision statement, theory of change, and then a logic model that shows how you're going to go about implementing that theory of change. So I'd look for those three things. I'd look that there's a plan, a documented plan to address the immediate needs of the target populations that you all have done analyses and have come to know to need services. And this includes, I'd be looking to see if these needs assessments include or point to strategies that address systemic and structural barriers to accessing services. So you're going to have to do there's two aspects to this target population analysis that you're going to have to do. You're going to have to look at it from the FFPSA lens, right? So determine your FFPSA candidacy population. And then you'll have to also look at it from a non-FFPSA target population lens. So those are those populations that wouldn't be FFPSA eligible, but would be eligible for services that are funded by the state block grant. Right? So those are two aspects of your needs analysis you're going to have to do. I'm going to look for whether I can see clearly that the core components of the integrated core practice model have been incorporated into the plan. Right? And Richard's going to talk a little bit about what would that look like to have written something into the plan that would work. I would look for a shared understanding, and this goes to Dana's point, shared across sectors and including meaningful collaboration with those folks with lived experience and those populations disproportionately represented in your child welfare and probation populations. So I'd look for shared understanding, right? And you can include public health, you can include education. Jennifer Rolls-Royce going to talk about that a little. But there's a shared understanding across these sectors of what evidence-based practices we have, what prevention, non-EBP prevention services we have, what are their utilization rates? I mean, have they been successful to date or not? What are the funding sources that have traditionally been funding them? And can we leverage those? Where have those services been provided and where have they been successful? So I'd be looking for some sort of visual display that showed me that there's a shared understanding of all the services available. I'd look for a gap analysis that starts to then take your population needs analyses and look at what services they might need and then compare that to what you have and then make some proposals about expansion or bringing new services. And what the other thing I'd be looking for is that the selected services, the new ones, get integrated without redundancy or supplantation into the current local prevention services array. And lastly, I'd be looking to see, have conversations been initiated with training providers, with EBP purveyors who might provide model fidelity services, model fidelity monitoring services, for example. Have discussions been initiated at the local level about contracting and statements of work? Okay, so those are all things that I'd be looking for to say, okay, this jurisdiction is ready to start thinking about implementation of a plan that they've put together. So, you know, without further ado, I'm going to turn it over to Jennifer Rolls-Royce. The CPP requires that you provide a theory of change and a logic model that is associated with it. Right, Jennifer.
Thank you. All right, well, I am going to provide kind of a brief overview of two key components in the development of any new program, a logic model and a theory of change. So as you're developing your comprehensive prevention plan, these will help you clarify what you're doing and why, and also help communicate that overall vision for the plan more clearly. Next slide. Okay. So just a quick quote to give you an idea. So what are theory of change and logic models? At a very basic level, they are brief written descriptions of what you plan to do and why. And they identify the outcomes that you're trying to achieve and the path that you will take to get there. So if you don't know where you're going, how are you going to know when you do get there in the end? These lay that out for you. Next slide, thank you. So why are we talking about these? Obviously, these are good practice for any program design, and we use them on the California Evidence-Based Clearinghouse a lot. We're talking about them today because the state does require that each comprehensive prevention plan have a theory of change or a logic model. It says or, so while only one is required, they really go hand in hand, and it makes sense to have both. We'll talk a little about what each is and how they're similar and how they're different. And you can kind of see which makes the most sense, but again, strongly encouraged to do both of them. And as I think Kush mentioned earlier, we'll be dropping a lot of links today to resources. So you do not need to frantically write those or copy those links. You will get all of the links that are shared today via email after the webinar. Okay, next slide. So what is a theory of change? Basically, it's a way to explain the actions you're going to take and why they will have the desired outcomes. If your major outcomes are things like strengthen families and reduce child maltreatment, which is what we're getting at with this effort, your theory of change would focus on the actions that you're planning to take and how each would lead to stronger families and the reduction in child maltreatment. And as you develop your theory of change, you're thinking about how and why the actions and strategies you take will have the desired impacts. It helps you identify what is actually driving the change. Next slide. So here is a kind of a brief picture of what a theory of change could look like. There are many different formats for writing out a theory of change. I like this basic one from a recent Annie E. Casey guide, and we'll drop a link to that, or maybe we already did. Thank you. It just provides a brief kind of shareable overview. This could be something you might share with your CPP stakeholders to give them an idea of where you're going. You'll likely also have a much more detailed version that your key staff are using and referring to as the plan rolls out, but this could be a kind of a snapshot of what your theory of change is. As you can see at the top, you start with your strategies and your actions, and then you walk through the outcomes that will ultimately get you to your goal. Keep in mind that the number of levels can vary as needed. This example gives you 3 levels of outcomes. And then depending on the number of strategies, you'll need to expand as well. And we'll talk later about how some communities may identify a couple of candidacy groups, others may identify a larger number. And that will obviously affect the complexity of your theory of change and how you're going to structure that. So you use the theory of change to clearly show how and why the strategies get you to the outcomes, and then ultimately your goal. So just to give you an example, if your strategy is increasing access to subsidized childcare, okay, you've identified that as a need in your community. We'll talk about needs assessment in a few minutes. Your outcomes could be things like more stable employment, with the reasoning that if you have better access to childcare, parents have the ability to miss less work. They're not having to cover that. And so employment is more stable. And consequently, if you have stable employment, it may also lead to increased household income or reduced family stress, other indicators and outcomes like that. And then finally, that leads you to increased economic stability, both in the community and in the individual families that are impacted by that strategy of subsidized childcare, ultimately leading to strengthened families and communities overall. That's just a very brief walkthrough on that one. Next slide. So for theory of change, you may have done these before. I know they're commonly required by many funders to provide a theory of change for any effort, but there is a lot of help as you develop your theory of change. Certainly what we just talked about is not going to be enough to help you completely do it. So here are some additional resources in case this is new to you or you just want some additional support. I've got 3 key places to get assistance, but there are, again, many other resources available on the web. If you're working with a consultant in your county, they may have resources as well. So first, Annie E. Casey has the guide that we mentioned that I think we already dropped a link to. They're also hosting a webinar next week on using the guide. And so that might be a great place to get started if theory of change is new to you and you need some extra support on walking through that process. We also have our own local strategies technical assistants here in California. They can assist with developing a theory of change. You may already work with them and have a contact with them, but if not, we dropped a link to that, I believe, as well. They also have a template on their website that you can fill out. I like templates, it's very concrete. So if this is new to you, and you don't know where to start with the template. It's a great place to begin. And then finally, the Capacity Building Center for States also has some great resources on theory of change that are tailored for child welfare and related populations. All right, next slide. So that was a quick overview of theory of change. Now let's talk about logic models. So while a theory of change is about explaining how the change will occur, a logic model is more about describing what will take place to achieve that goal. A logic model is like a detailed picture of exactly what will be done and is guided by the underlying theory of change. So that's why I said they really go hand in hand. A good logic model is based on a theory of change. And again, you can have many different formats for a logic model, but in general, they all contain things like inputs, outputs, outcomes, etc. On the CEBC, we ask the programs we review to provide a copy of their logic model. So if they've shared it, you can find it on the website if you look at the posting for any particular program. All right, let's take a look at what a logic model looks like. Next slide. All right, so here we have a logic model, and this is for a system-wide effort to develop a more trauma-informed child welfare and mental health system. It is pretty detailed. It reflects that system-level program. Don't get bogged down in the details right now. I know you're seeing a small screen, but let's just walk through the components of the logic model that are listed at the top. So first, starting from the left, you've got the inputs. This is basically what you start with and what you're putting in. So you can see things like funding, you've got staffing, you've got resources, et cetera. What are you beginning with? And then you move into your strategies and activities. What are you actually going to do? And again, these are concrete and different levels. Here they have kind of 6 groupings. And then for each of those, you move into what we call outputs. Outputs are more like process level outcomes that show you that the activities actually occurred. And they're things like counts and percentages. So did all staff actually get trained? You can measure that easily. That's an output because actually just receiving the training doesn't actually tell you if it changed anything. These are just process. The outcomes really get to the meat of what you're trying to achieve. And in this logic model, they've broken them down into short, medium, and long-term outcomes, which I think makes sense for any child welfare effort because we know that change like this really does take time. You can see things like provider knowledge and skills immediately after a training, but establishing collaboration, which we know is so key to this effort, and changing child and family outcomes and community level outcomes is going to take more time. So you'll want to think about short, medium, and long-term impacts as you're developing the logic model. This logic model also has some assumptions at the bottom, both strengths and challenges. And I think these are also very important to include in a logic model. We know that there are going to be things that are going to help you and things that are going to hinder you in this process. So keeping those in mind as you're working through your logic model is a great idea. Okay, next slide, please. So we have a few key supports that can help you as you develop your logic model. Just a few listed here. A key one, for anyone in the child welfare or the family serving field, is the Friends National Center. We've got the link, and I think that's been dropped. Yep, thank you guys. The Friends National Center has a ton of child welfare focused resources on logic models, including a logic model template that you can fill out. I love a template again. They have a searchable database of outcomes and indicators. And so this is great because if you need help figuring out how to word some of those things, if you aren't always thinking in kind of measurable examples, they've got them and they're child welfare specific. So they're pretty ready to go. They also have a whole database of measurement tools. So a key thing with a logic model is that your outcomes and indicators can be measured. So you can look at their suggestions of what other people have used to measure certain outcomes. And again, they're directly linked to those outcomes and indicators. So a great resource at Friends. They also have, I think, 4 or 5 self-paced online learning courses on logic models. So if you like, the self-paced model, you can go ahead and go to their website and sign up for those courses. If you like live training, Caltern is going to be partnering with them on a webinar in October. So kind of an intro to logic models in October. And then 2 weeks later, we'll have a follow-up kind of more interactive workshop where you'll actually have a chance to talk to the Friends staff, get some questions answered, et cetera. And registrations for that, I believe, will be opening in early September. So a couple other resources we have listed. The Kellogg Foundation has a guide that's really useful. And also, again, the Capacity Building Center for States has some tools that are very applicable. All right, next slide. All right, so there are clearly a lot of similarities between the logic model and the theory of change. As I've said, they go hand in hand, and it's really helpful to do both. The main distinction between a logic model and a theory of change is that a logic model describes a logical sequence between what the intervention's intended outcomes are. So if we provide X, the result will be Y. While a theory of change includes those kind of causal mechanisms that show why each intervention component is expected to result in the intended outcome. So if we provide X, A will support a result of Y. It's a little bit more complicated. Overall, a logic model is descriptive, while a theory of change is explanatory. So again, they really go hand in hand, but slightly different. Also, a theory of change works to understand the context in which a program operates. So we recognize that factors outside of this comprehensive prevention plan are going to influence your end result. And so a theory of change works to take that into account as you're moving through the stages. A logic model, on the other hand, really focuses much more on the program itself and how it's operating, and less on those external factors and how they can impact the activities. All right, I'm turning this back over to Kush, I believe.
Moment, but I'm going to turn it over to Wendy Wegman and Mike Steele. So, I mean, in order to devise an accurate theory of change and logic model, you're going to need to know who your target populations are, right? Both, from a from a primary and secondary point of view and a tertiary prevention point of view. So that's what Mike and Wendy are going to talk about. All right, hang on one second. Okay. Well, population data.
Good morning, folks. It's a pleasure to be with you today. It's wonderful to see so many attendees. It looks like there's 150 folks on the call plus today thinking about how to develop these comprehensive prevention plans, and I couldn't be more excited. Next slide, please. Today, Mike and I are going to be talking about how you define the populations that are eligible for prevention services. And just as a reminder, this segment that Mike and I are handling are meant to help you with the comprehensive prevention plan element of describing and providing a rationale for the selection of candidacy populations that are going to be prioritized in your plan and the services that you're going to include. And so hopefully what Mike and I will give you are some good thoughts and ways to go and grab some data that will help you begin to describe and provide rationale in that part of the plan. Next slide, please. So just as a reminder, the comprehensive prevention plan is able to discuss all three levels of prevention. So primary prevention, I know that you've probably discussed this in some of the other learning forums, but because we'll be touching on each of these separately, we just wanted to provide a small little primer on these different levels. So primary prevention, which Mike will speak to after me, is activities directed at the health and well-being of your sort of community, using the social determinants health, really thinking about is our community supportive of children and families? At the secondary level, we're thinking about family resources, centers, and other types of providers that are starting to address things that are associated, risk factors that are associated with child maltreatment. And so this might be domestic violence or mental health, substance abuse. And so those providers are out there in your community trying to support children, families, and adults in addressing these risk factors. And so secondary prevention is starting to think about maltreatment a little bit more specifically and addressing those risk factors before they turn into abuse and neglect. And then the tertiary level of prevention, where I'll be focusing my talk around the data sources, is really those we're already aware of the families and we're already somehow involved with families because abuse and neglect has occurred and been reported. And so we're actually involved with children and families in to help prevent re-abuse and to help mitigate the impacts of that abuse and neglect. Next slide, please. So the ways that these three types of levels fit into the funding streams that are available in the state of California for your comprehensive prevention plan is that the state block grant is a broader pool of money that is sort of used best for your primary and secondary prevention. And the description of who's eligible to be a candidate within that block grant is much more open-ended, culturally appropriate and responsive services tailored to meet the needs of families who tend to be disproportionately represented in our child welfare system. And so this is the sort of broader pool of money that either address those secondary and primary levels of prevention or try to get to those culturally appropriate and responsive services that may not yet have reached the sort of evidence-based practice levels that are deemed appropriate under FIPSA. Within the Title IV-E funding that comes from the Families First Prevention Services Act, there's very specific mention of sort of who is a candidate within that funding, and those are children at risk of entering foster care. And even though that's fairly open-ended, the state letters have given us more concrete thoughts about how to identify those populations, and that sort of more tailored group is really in that secondary and tertiary levels of prevention. So we're actually going to work from small to large. And so I will start after Mike gives us a little bit of thoughts around sort of okay, now we have to define which of these populations we are going to serve and what are the factors that we should really be taking into consideration as we make these plans. We'd probably all want the biggest prevention plan that we can have, serving all the families in the world. But as we know, resources are finite and limited. And so we have to make very concrete plans about who we can actually serve with good fidelity. So Mike, I'll turn it over to you as you lead us through that conversation a little bit.
Thanks, Wendy. Next slide, please. Oh, thank you. So, oh, next one. There we go. Thank you. So as Wendy was saying, there's been some guidance given in California's 5-year prevention plan, where they name 10 groups who will be eligible for services. And when completing your comprehensive prevention plan, you can identify which of those you plan to implement services for. But when considering which ones you'll be choosing, there are a lot of different factors to bring into play. And candidacy can really be considered as a continuum from narrow to broad that allows you to leverage preventative services to stabilize populations and prevent child removal. Next slide, please. So I just wanted to show you quick what the continuum might look like. Each one of these dots represents either a submitted or approved FFPSA 5-year plan, and the numbers indicate the number of candidates that each one of these jurisdictions has chosen. And this is by no means the comprehensive overview of all of these plans, but what I wanted to show you was that some places like Utah have only picked 2 candidate groups, and others like Arkansas have 17. So there's a lot of flexibility here. And as you move from narrow, right, which could be something as specific as indicated or substantiated investigations not resulting in removals, that's probably the narrowest part of the spectrum. You can go as far as families in community areas with a high confluence of known community level risks. So there's a lot of flexibility for you here to figure out what serves your county best. Next slide, please. So what are some of the factors to consider when deciding whether or not to go narrow or broad? The first is your capacity to deliver evidence-based interventions. So, are there community-based interventions available in sufficient numbers to serve the populations you identify? You don't want to select populations that you'll be unable to support. The next thing to consider is the workforce. So, as you move from narrow to broad, right, the number of families you're going to serve will likely get larger. And so making sure that you have the workforce ready and able to serve the population that, the size of the population that relates to the part of the spectrum that you select is really critical. Fiscal. So what's the financial burden going to be for the unclaimed portion of the prevention services? So there will be some amount of fiscal responsibility on the part of the counties. Estimating what that will be and making sure that you can live up to that requirement is also an important factor to consider. And then finally, technology. So what IT system modifications will be necessary to capture or document the preventative service provisions and case management activities? Claiming requires a certain amount of data and documentation. What we have found in many jurisdictions is that they may have parts of what they need in order to provide the information for claiming, but they often don't have all of it. And sometimes it's a simple fix, and sometimes it's a complicated one. So understanding, what your responsibilities will be in that domain is also important. Next slide, please. So I just wanted to give you an example. Hopefully this won't be overwhelming, but sometimes when at Chapin Hall, when we're supporting a partner jurisdiction, we'll go in and we'll help them understand what the numbers are in their system. So as you look at this infographic, I guess, or graph, from left to right, from hotline to kids entering the system, you can see the numbers kind of get smaller, right? So at the hotline, you've got the largest number, and as you move into the system, that number gets smaller. And so the way we do this with our partner organizations, we'll start with, sort of the far right side of this graph, and we'll say, you're currently serving all these kids in the system. As you move down that continuum to prevention, you're sort of moving to the left on this graph, and the numbers get larger. And so if you want to serve, for example, all of the children who remain in home, that's a population of about 23,000 kids. are you ready and able to, to serve that population based on the domains we just discussed on the previous slide? Maybe that might be too much. Maybe you would want to only serve those that are intact and voluntary, which is about half that number, because that's what you have the resources for. Another way to use a graph like this is to also consider what programs you have available to serve any one of these bubbles. So you don't have to necessarily do anything this complicated, but it is sort of useful to at least sort of estimate ahead of time as you move services and interventions towards the preventative part of this flowchart, the size of the population you might be serving. Next slide, please. Oh, I think I turn this back over to you now, Wendy.
That's right. So folks, we're going to start at the tertiary level, as I mentioned, and talk about potential data sources for identifying and enumerating the number of candidates that you would need to serve. And so we'll go to tertiary and then secondary, and then Michael will lead us through the rest of the primary levels. This graph is really just to, or this table is really just to show you sort of what data is readily available for you, what data might require a new or brand new sort of analysis of CWS CMS data, but the data are actually available in a field in the data system, or potentially in the third column, this data might be in SDM if you're using those tools in your county, and you could then pull that data out of there. So in terms of the candidacy descriptions, we've got substance exposed newborns. We do know that we've been we have a new field, and we've been starting to use these sort of plans of safe care for substance exposed newborns. As structured decision making is what SDM is. It's a tool that some counties are using to do risk assessments. As substance exposed newborns, we have this field in CWS, we're starting to use it, and so perhaps we can start to pull out that data and start to enumerate who's come to our attention in terms of newborns that may have been substance exposed. In terms of domestic violence, substance use disorder, and mental health issues, domestic violence in particular, there is a field in one of the risk assessments through structured decision making. If you're using that tool in your county and you get that data from evident change, you might be able to get some frequency counts of the families that were referred and had indicated risk, and then had this as an indicator of why there was risk. Children of parents with the substance use disorder and mental health issues, same thing exists in the risk assessment and structured decision-making tool. So that might be a good source of data. Alternatively, there's a field in the when you substantiate an allegation, there's a sub-abuse field that we know is available, but has very low data collection in our analysis. A lot of missingness on that sub-abuse field that exists in CWS CMS. But if you were to start utilizing that field in your CWS system, it's actually a very easy field to start analyzing and getting some frequency counts around. And then you'd be able to enumerate the number of family parents, children of parents with substance use disorder and children of parents with mental health issues if you were to start utilizing that field that exists in CWS CMS. Homeless or runaway youth, we also may have some indicators in CWS that those folks are there. Trafficked youth, again, if we were to pull down data from CWS, you can easily identify these young kids. They're just not existing reports either on QUIP or Safe Measures websites. Same with probation youth that might be subject to a WIC 602. We do have some data that identifies those children that are probation involved that are in out-of-home care, but other youth that might be probation involved that are not in out-of-home care, you're going to need to use your CWS data to start to enumerate those. And then children whose adoption or guardianship is at risk of disruption, there's not a single field that you could use to identify those young people, but you might think through some of a combination of fields. One of our analysts here at QUIP has started to think really closely about adoption and guardianship disruption and what's going on with that. And we have some early thoughts about how we might use fields in CWS CMS to analyze those. The rest of the ones that have checkboxes in that first column, those are reports that you can easily grab from either the QIP or the Safe Measures website. And so we'll go to the next slide, Kush, and just quickly show, at least on the QIP website, where those reports will be at. This slide is extremely small, but it's not meant to be that informative. Thank you, Stephanie. There's a handout actually that was just put in your chat that will actually provide you step-by-step instructions about how to find these data. But we'll walk quickly through the QIP website to help you kind of at a brief snapshot identify the reports. So if you wanted to identify children with a substantiated or inconclusive allegation, click please, Kush. You could find that under the fundamentals section. Click again, and that will take you to the report that will help you identify the number of children for whom we have a substantiated or inconclusive allegation. Just as a quick pause, the links that are provided in the handout that Stephanie just put in the chat and the screen captures that I'm showing you right now are from the public-facing website. Those of you, my friends in the counties, know that there's also a secured website where you can actually get the specific data, more granular, no masking, right, to protect confidentiality, the full data, and all the breakouts that you might want to have. So just be aware that we're showing you captures of the public website, but the secure website is always there available for my county friends. Next click will show you families receiving family maintenance services. You can find that easily on the QIP. Again, another click, that report will take you something over there. It'll be frequency counts of children that are in FM, and you can look at those both voluntary and court-ordered on that report. Next click, you can click twice. Children with siblings in foster care also easily identified using QIP reports, and so you might be able to go in that direction. And then give me another 2 clicks, Kush. And then we got pregnant or parenting youth in foster care. We also have reports enumerating the frequency of those youth in the foster care system on the QIP website. So we hope that at least at the tertiary level, you've got a lot of resources that can really get your ball rolling in starting to pull together these sources. Next slide, please. At the secondary level, it's a little bit more complicated because, again, if we go back to one of the first slides that I was talking to you about, these are sort of identifying populations of people who may be at risk of abuse and neglect because these other things are going on. And so we've been thinking a little bit beyond our CWS system, either through QIP or through Safe Measures, to try and identify additional data sources that can help you identify some of these additional candidates. One of the best places I think that I can wholeheartedly endorse to find a lot of good data is kidsdata.org. You can see that kidsdata.org can help you identify the number of children with exposed to domestic violence. You might even find better numbers around parents with substance use disorders from a study there. Children with parents with mental health, that might not be perfect because it may not be comprehensive of all types of mental health issues, maybe focus more on depression, but at least you can get some early baseline figures that might be put you in the ballpark of what you're looking for there. Lots of data on poverty at Kids Data, but also we do have numbers of children in poverty on the QIP website, children of young parents. So there's some adolescent parenting measures on kidsdata.org. And beyond kidsdata.org, I'm sure that there's other data sources, but they're just not as immediate and sort of really nice. I went through each of these and made sure that there was county level data and also that it provided frequency counts, because essentially what we're trying to do is develop numbers of the number of people that we're going to serve. In terms of substance abuse, exposed newborns, children of parents with disabilities, and children with disabilities, those are a little bit more complicated. I don't know of any ready data sources, but would be happy to and open to suggestions if you know of something. But if we're thinking about it, you might just start to partner really closely with your own agencies within your county. Health insurance billing can help you identify these various pools of children. Hospital records, if you are able to link those or find those records, are available. example. Regional Center is a good place to go looking for data on parents and children with disabilities. The American Community Survey also will help us enumerate the number of children with disabilities. So we'll go to the next slide really quickly, and I'll just show you a brief, very brief example of kids data. As you notice, we had lots and lots of suggestions there to go to kids data, but give me a click, push, and you can see that at least there's a report on the domestic violence calls for assistance. You kind of have these reports at the county level where you can definitely see the number of kids for whom there were calls for around domestic violence. So interesting data that's available to you. We hope that that gets you really going and thinking about some of these levels. I believe I hand it now off to Mike to go ahead and talk to us more about the primary level of prevention.
Thanks, Wendy.
Got it.
Next slide, please. Thank you. So I just want to say a little bit more about this primary level. Often at this level, we're talking about things like social determinants of health. And for those who are not necessarily familiar with social determinants of health, these are basically economic and social conditions that influence, individual and group differences in health status. So said differently, all of us are individuals, and we have individual characteristics that would lead us to have certain needs or interventions or risks for things, and choices and behaviors that we have or make can influence that. But none of us are an island. We all exist within different systems. We exist within our household, within our neighborhood, within our community, within our state. And so all of those different levels of systems can influence our health outcomes. And that's kind of the idea behind social determinants of health. What are these community level characteristics that are present that may increase our risk or for a particular need? Unfortunately, while this is a very popular topic at the moment, there is no exact agreed upon taxonomy or criteria as to what should be considered a social determinant of health. Next slide, please. Now, according to the CDC, there really are 5 main elements. And so I think we're going to go with them because they're a pretty authoritative source. And they are economic stability, education, health and mental health, neighborhood and environment, and social and community. And what I want to try and show you here are some resources that you may be able to use in California to better understand these dimensions of your individual county or jurisdiction's social determinants of health. Next slide, please. So, CDSS in the 5-year plan reflected a few examples of what some SDOH metrics could be. And so I went through and I tried to find places where you could locate information on this. And this list by no means needs to be the end-all be-all. It is simply a set of suggested measures to start with. So things like substance use, mental health, poverty, economic stability, most of the things listed here you can find on the Healthy Places Index website. Now, there are a few where the county health rankings might be better, but I really wanted to spend some time on the California Healthy Places Index because I think it is such a great comprehensive tool that will allow you to better understand some of these determinants. Next slide, please. So here's sort of an overview for those of you who are not familiar with the Healthy Places Index. It's made by the Public Health Alliance of Southern California. And what it is it's a summary index. It's meant to measure health disadvantage. And so they define that as the inability of people to fulfill basic human needs required for full social participation and optimal health and well-being. And then they list a bunch of the dimensions that go into this. So this summary statistic really is made up of a lot of different individual measurements that they sort of average together and they sort of classify the counties. And so this map you can see this is all the counties and this is their Healthy Places Index. Blue counties have a lower score, green counties have a higher score. And this summary statistic in and of itself may not be particularly helpful for what you're doing, but what's great about this website is you can get at all of the data that gets added up and summarized into this score. Next slide, please. So here's an example. One of the things that is available within the Healthy Places Index site is you can go in and click on the View Indicators tab. And within that, you can choose any one of the individual indicators, and there are a lot of them in here, that make up the score. And so one of them is a survey of people's mental health, where they ask if their mental health is not good for a particular period of time. And so you can see on the left-hand side at the county level, this is a measurement of that particular indicator. And if you click on any given county, it'll give you a whole bunch of sort of really great benchmarked metrics. But what's particularly great about this is the map on the right side allows you to drill into really specific levels. So this is the same metric. I've zoomed into Sacramento, and we're looking at the zip code level now instead of the county. So you can see within counties, and you can even go down to census tracts with this, what the score is. And there are multiple years in here too. I think there's 2 or 3 years of these too. So you can even do little trends to really help you target where you might want to think about primary prevention interventions around, mental health well-being. How can you help folks in particular parts of your county achieve more well-being or mental health stability? They also have population numbers in here, so you can actually start doing estimates of prevalence and really come up with some good numbers around what the need for services are. Next slide, please. Okay, I don't remember who's doing the tribal data. Oh, go ahead, Wendy.
So this is just a slide to remind us that it's absolutely critical that in our prevention plan that we engage with the tribes to also help them identify their populations that we want to provide prevention services to. So just as a sort of primer for this, there's not necessarily great data that we have from or about tribes that are not being served within county systems. So we know that if Native children are being served by counties, we're probably using CWS-CMS to engage with those families and case manage and do data collection. And so that sort of those children are already included in what we might be able to look at least at the tertiary level. Just to give you a primer, there are 109 federally recognized tribes in California, with an additional 78 entities that are petitioning to be recognized. This is a huge Native American population and the largest in the country in the state of California. So even though we might often reference that there's very small frequencies of Native American children, I think that we might be underestimating the degree to which that's true in our state. CDSS has Title IV agreements with the Yurok and Karuk tribes. This recognizes their sovereignty and right to operate their own child welfare systems. And so those specific 2 tribes that are located in Del Norte, Humboldt, and Siskiyou, they might have data systems since they have an operating child welfare system. And so in those counties, you might want to have really specific conversations with those 2 tribes about what data systems they're using, if any, and how you might be able to try and get some data from them about the number of children that they would identify at candidates at all 3 of those levels. We do have data that does identify for those youth served by counties, children that either are ICWA eligible or have primary or secondary race or ethnicity as being Native American, and those data can help us quantify tertiary prevention needs. But again, those are only going to be children that are served already within our county and state system. To dig deeper into the primary and secondary prevention needs of those communities, obviously you're going to need to talk with those tribal communities that live within your counties. If you're struggling to identify tribal leaders, or you don't know which tribes may exist in your counties, you can obviously reach out to the CDSS Office of Tribal Affairs, and they will both help you identify who's there for you to talk to and perhaps some identifying information so you can reach out directly with them. So just want to make sure that this point doesn't get lost. We are also trying to help and support and create prevention for our tribal partners and our tribal communities as well. And so this may take a little bit more work and rolling up your sleeves, but this is a part of what we're doing in our comprehensive prevention plans. Thanks so much. I believe we're on to the next slide.
Absolutely. Thank you so much, Wendy and Mike. Now we've visited the land of needs assessment, right? And target populations, the who, Okay, so now we're moving to, okay, how are we going to serve the who, right? This is the who was the first part of your logic model, right? Now we're moving to the second column of the logic model, which is the what service strategies are we going to use? And so we're going to have Jennifer come back and talk to us about that.
Great, thank you. So I am back again to talk briefly about asset mapping and examining your existing service array. Asset maps are a common early step in the work that we do with counties and agencies on the CEBC. You know, when you're looking at bringing in any new evidence-based practice, you first want to look at what services are currently in place and decide how and whether you need to fit a new practice into what you're doing. And so that's obviously a key step in developing your county comprehensive prevention plan, looking at what you're already doing, not just in child welfare, but across all of these multiple sectors we've been talking about that will need to collaborate on this effort. We know there's a lot going on, and so we need to start by looking at that first. Next slide. Okay. So asset mapping is a required part of the CPP, but there is no exact template or specific form you have to use. Just as with the logic models that I talked about earlier, asset mapping can be done in a lot of different ways. And although it uses the term map, you do not need to turn in an actual map to CDSS as part of your plan. If your county has access to people who can turn data into maps, like you just saw in some of those data examples that Mike presented, that's great. It will certainly help you see the locations better and understand your data, but your map can also be more basic. You could focus at the community level, et cetera. So you don't have to go fancy if you don't have the ability to do that. The important point is that you're able to understand what services you have and where they are in your community or your county. So Mike and Wendy just reviewed ways that you can get data on who needs to be supported. And I also saw that Richard put in a reminder that those are not the only data sources. There are plenty of others. So probation, mental health, First Five, all of these places will also have other data that can help you. Okay, so you've looked at data on who needs to be supported, and you've identified some candidacy populations. So now you've got to start figuring out how you're going to best support them. You want to start by examining what you're already doing. So to do this, you'll need to work with your team, your CPP planning team, your partners, anyone who's involved, and find out what's currently available. You know, what can we do with what we already have to get what we need? Look at your existing data and reports, all that stuff that we just talked about. Find out if anyone has already done a formal mapping project or has looked at services, done an asset map, and if so, you can build off that. On the CEBC website, we've got some materials that'll help you get started as you look at your current assets, and I think they just dropped the link. Thank you. So again, you know, these are just examples. You're going to want to do an inventory at your local level. You know, what are the existing annual reports? Things maybe to your board of supervisors or a board of directors. Have you done community self-assessments, you know, system improvement plans, reports to funders or to grants, et cetera? So it's really starting with what's the data that you already have and seeing if that fills your need. You may also have to do some new data collection, such as a brief survey or a focus group if you really can't find the information that you need. And so that, you know, can also be a part of your asset. And I should just point out that asset mapping, we also sometimes call it service array or service inventory, especially when we're focusing on programs and services. They're all really the same, just different terms for really the same process, looking at what you currently have in your area. Next slide. All right, so not sure where to begin. So we'll start with this table that was presented at the June 29th webinar in this learning series. And I think, yep, thank you. We're dropping a link for that. In case this table is new to you and you haven't been with us for the whole series, let me just do a quick orientation. Across the top, we have those social determinants of health, the SDOH that Mike talked about. And we are using, again, the CDC version of those groupings. So we've got, you know, economic stability, education, health and healthcare, neighborhood and built environment, and then social and community context. Okay. Right below that, the next row has the protective factors. So if you're in the prevention field, you're probably familiar with either social determinants of health or the 5 protective factors. If not, welcome to them. We can provide some additional resources. I know we've dropped a lot of links, but we have more information about both of those. These are really the 2 major prevention frameworks. And so the protective factors are more at the individual level. Do you have concrete support in times of need? Do you have social and emotional competence of children? Do you understand child development, et cetera? So again, just 2 different frameworks, and this table kind of gives that comparison. The next 2 rows get at service need and also examples of services. And in the service example row, the color of the font indicates the prevention level, with black being a primary prevention service, red being a secondary prevention service, and blue being tertiary. However, keep in mind that services can actually cross multiple prevention levels. So for example, on this one, we have home visiting listed in red, meaning it's secondary. But the reality is we know that home visiting programs, depending on the specific one that you use, can be used for both, primary, secondary, and tertiary level services. So as you're examining, as you identify your priority populations and your areas of need, you can use this list to help identify what types of services you need to map and list and identify in your asset map. You'll need to keep in mind, again, that these are just examples. This is not an exhaustive list of the services. So you'll want to start with some local brainstorming in your planning groups to think about what are other services that are currently happening in each of these areas. Next slide, please. All right, so that table was very busy. So I'm going to just have a zoom in a bit and just look at the service need row for primary prevention. Again, it's organized by the social determinant of health at the top. So what we're showing here are the services and situations that you would want to see in a healthy community. So for example, in a community that has strong economic stability, that first box, you'd expect to see, a good number of banks that are operating. You'd want to see good childcare programs available. You'd want to see job training and financial literacy programs available. And then probably most importantly for our families and ourselves, you'd want to have food supply, food sources, food providers, housing that are all available and affordable within that community. In the other boxes, you've got things like education, where you would expect to see, both quality education, quality early childhood education. Under health, you have to have access to services. You would expect to see, prenatal care readily available. In the neighborhood and environment box, you'd want to see things, again, like access to nutrition. We talk about food deserts occurring where there are a lack of healthy grocery store type food options in some communities. Or it could be a clean environment. Do you have issues with, with trash, with graffiti, things like that in certain communities? And then lastly, under social and community, it's involvement, it's social networks. Are people working together in their community? So these, again, are the things that you would see, and they all help prevent communities and the individuals that live in those communities from becoming unhealthy. Okay, next slide, please. Thank you. So now we're looking at the exact same social determinant of health groupings, but this time we're looking at primary prevention service examples. So these are services that would help, again, prevent that community and the families from becoming unhealthy and at risk. And you can use these to help you organize the assets that you'll want to map and examine in more detail. Again, you're not expected to map every single service occurring in your community. You're going to focus on the services that address the candidacy populations that you identified in that earlier stage. Okay, so I don't want this to look too overwhelming. So let's just walk through the neighborhood and environment here. So some examples of services that we have listed would be access to grocery stores. Is there equitable distribution of grocery stores across your entire county? Or are there areas where folks have to drive or take transportation a long distance to get to a traditional grocery store? Do we support merchants who do provide healthy options? Looks like we've got a typo in that one, but sorry about that. Healthy options in areas where grocery stores may be less accessible. Do we have community safety initiatives and things like legal aid or immigration support? Who's providing gang diversion programs? What's going on with those? Or things like community beautification, clean air initiatives. So these would be things that you would want to look at if neighborhood and environment is one of your priority areas that you're addressing. All right, let's give an example. We're going to go back to that first column, economic stability. So if you've identified children experiencing poverty as one of your priority populations, that's one of those 10 options, you can use the services in that first column to begin examining what's already available in your county and where the services are located. So for example, you have food banks, but where are they located? Are they in the areas that really need them? How many people do they serve? Are they sufficient? Do we need more? Where are the people coming from who are visiting those food banks, et cetera? Some of this starts to cross over into the gap analysis that we'll talk about later. But at this point, you're really gathering information on what's available there. Same thing with job training programs. Where are they? How available are they? What's the capacity? Subsidized childcare spots. Again, how are they distributed in your community? If you've got information about where poverty is occurring, which you've got from the data sources that we talked about earlier, you can start seeing whether the services that are needed are in the correct places. And with the gap analysis, you'll start to really kind of quantify that and decide, is it where you need it to be? So how do you find this information? Again, you want to focus on the candidacy populations that you've identified and start with your CPP planning group. You're going to have to find out who's working in these areas. So you want to make sure that you have strong representation from the communities and populations you want to focus on. If you don't have people who can answer questions about who's providing job training, if that's an area of interest, you need to go out and get those people involved. You can also do things like look at your CDSS or OCAP grantees. There may be people in your community who are getting funding from the state to work on some of these things already. Look at your system of care groups, your behavioral health contractors associations, if you have them. 211 is an excellent way to go look at who's providing what type of service. I think Mike is going to talk more about 211 later, but I know here in California that just as we can use it to refer people to services, you can also pull their data and look at who are all the service providers, where are they located, and what do they actually provide. So that can be a great resource that can help you with this asset mapping process. And again, look for the existing data, existing reports whenever possible. If you really can't find anything, you may need to go out and collect some new data, but usually there's going to be something at least to get you started. Okay, next slide. Another common way to put this, if you're looking for how to find these providers and where they are, is to follow the money. So we've got here some common funding sources that are listed by the Social Determinant of Health. These may be active in your community across all 3 levels of prevention. You can look at what each source is funding in your county. And keep in mind, these could be funding that's going through probation, through mental health, or through child welfare. Again, all different funding streams, but you've got that collaboration that's working to develop the CPP. And so hopefully you can all start identifying. You can look at contracts, grants, annual reports. What services are they providing through these funding sources? And then what data do you have? Where are they serving? How many people are being served? What types of practices are they using? Evidence-based practices, not evidence-based, and so on. So really in the asset map, in this service array examination, you're just reporting on what's currently out there based on the information that you can find so that it gives you a place to start as you look at what your community, the candidacy populations that you've identified, are going to need. You've got to know what your baseline is before you figure out what you're going to do next. So we've been talking about primary prevention. Let me just give you a couple of examples now. You can repeat this process for every level of prevention, and you can go back to that big complicated table and pull this stuff out. But here's a slide just on secondary. And these are service examples focusing on, oh, sorry, thank you, Advanced Next, I got it. Focusing on how you're preventing harm for those who are already at risk. So for example, you might offer wraparound services or respite care to families who are at risk and who need that extra support. You're probably not going to offer those at the universal level, but you would do it at the secondary level where there's already some concern, some risk. You may have crisis lines already in place. And by nature, those crisis lines are picking up, calls from people who are saying, I need help. I'm already, I'm in crisis. I have issues. So you could look at where those are, what they cover, who's using them, and so on. Okay. And a key factor, and this will come up again in the gap analysis, is capacity for all of these things. Because you may be saying, we have all of these in our community, but the question is, do we actually have enough to meet the need of the candidacy populations that you're identifying? So we'll come back to that when we talk about gap analysis. All right, next slide. So finally, here are some tertiary prevention service examples. Again, this is not an exhaustive list, it's just a starting point. But here again, we can see that there are some of the same services being used across prevention levels. So we've got parent education here. But parent education is commonly used in both primary, secondary, and tertiary prevention services. The content of the training would obviously be very different at each level. With a primary prevention parent education program would focus on general parenting skills, increasing parent knowledge and skills for all parents in the community. Whereas a tertiary prevention program like here would focus more on changing abusive behaviors that have already occurred and identifying more appropriate ways to parent. So you want to think about this is a type of service, and then there's specific programs within that type. And that's what you really want to map. So it's not just, is it parenting education? Is it, incredible years, or is it triple P? So it's getting at the specifics of what's being provided. Other things here, forensic hubs, family finding, et cetera. So these are clearly more tertiary when these families are already involved in the system. All right, I am going to stop there. Again, the actual process of asset mapping can be done in many different ways and will vary depending on the size of your community, the number of providers you have, et cetera. And there are a variety of concrete tools and guides that are available. So rather than dropping another extensive list, when you get the follow-up email, we'll have a list of asset mapping resources that you can look to for additional information. And I think I'm turning this back over to Kush.
Yes, absolutely.
Okay.
And we are about to take a break. And I did, before we do that, I know, and we've gotten this feedback that it's a lot, right? And so that's why we have a few breaks so you can digest. But the point of what you've heard so far is, if you don't know what you have for those you have in mind to serve, you're going to spend your state block grant money and or the 4E money that you eventually will draw down, not in a very strategic way. So the point is, figure out what you have so you know what you don't have. And we're about to get to that, so you can spend the funding strategically. So that's the context you want to keep in mind as we throw this stuff at you. Okay. Welcome back from break, everyone. Before we move to our next topic, I want to acknowledge, in the spirit of throwing a lot at you, that we have a lot of links. And if you don't have to click on each one. In the follow-up, we will give you the links again, right, in a document. So, and somebody's just dropped where the resources will be. So you don't have to furiously open links and then listen to the conversation at the same time. The part of why we've compressed so much into such a small amount of time is that you all have a comprehensive prevention plan due in January, right? And if you have a prevention plan due in January, you likely are going to have to start putting everything together around November, right? If you're going to go through your review cycles. So we want to make sure that you are equipped with the recordings of these, right? So you can take them back to your teams and listen to them more slowly, or listen to certain segments that'll help you start to do the thinking and the planning and the analysis needed to complete your plan. So we are certainly not expecting folks to be able to digest this all at the same time, but we want to, so I would invite you all to sort of sit back and get the whole of what we're saying, right? And then get into the details slowly with your groups on the ground. That said, right, if prevention were easy, we would have done it by now. And there, especially primary prevention, right, where we know you get the most bang for your investment, it's broad, it's challenging. So in some ways, there isn't a way to make this any less overwhelming, right, to show you where you might get the most bang for your buck, right? Instead of just tinkering around in the areas that we're usually tinkering around in, and we sort of get the limited outcomes that we get, right? So I just want to acknowledge it's a lot, and it is, and it's all needed, but you don't have to digest it all at once. All right, so I am going to share my screen now, and we are going to turn it over to our presenters once again. Good. Okay, so gap analysis. Michael and Jennifer.
Great,
All
thanks,
right.
Kush. I think I start this part. I want to just build off of the conversation we were having around asset maps and service inventories by talking about a gap analysis. And this is where we start putting a lot of these things together. Next slide, please. So what is a gap analysis? This is where we compare what's currently available, right? The asset map or service array versus what's needed. So the needs assessment, prevention populations, or candidacy groups that we've identified. And we really use this needs assessment data to examine, how it matches up with services. So there's some key questions it's meant to answer, basic things like, are services in the right place for people to access them? And access is a very complicated idea. In this context, we're mostly talking about, are they close physically or geographically to the populations that need them? I know there are lots of other dimensions to access, but that's not necessarily part of this right now. Another key question to consider is, how long are wait lists? Are there existing barriers to accessing these services, funding or transportation or language? And are their current services, are they achieving the desired outcomes? And so a lot of those exist sort of in a continuum, right? Like it might be harder, for example, to get to the desired outcomes piece than it is to do the first question, which is, are they in the right places? So don't feel overwhelmed if you don't think that you'll be able to answer all of those questions. Start where you can start. Next slide, please. So usually when we do a gap analysis, there are some expected outcomes or products, usually some kind of visual illustration of the gaps between needs and resources. Often there's some sort of optimized map or list that will recommend where to put new resources, like the specific location, or maybe suggest the size of capacity needed to meet a gap. We'll talk about this more in a minute, but there's kind of different levels of geography to think about when you're doing this work. Sometimes you do a global analysis where you look at all needs versus all services, and that's how you get to the capacity question. And sometimes you're very specific, and you say, in this particular part of my county, I need a thing that doesn't exist. And that gets to the next bullet point, which is hopefully the gap analysis will create a list of recommendations for how to shift or reduce any excess capacity where it's not needed, or add existing capacity where it is. Sometimes this is about sort of shuffling the chairs on the deck, but sometimes this is about actually increasing what you need overall. And what's great about this is it really gives you a quantitative rationale for when you make contracting decisions. And this can really improve your communication with the provider community. You know, if you want to reduce wait lists, being able to very specifically tell providers in very specific locations what you think are going to be needed in the next year can help you change around your contracting to adequately provide resources to make those sorts of things happen. Next slide, please. So again, what is a spatial gap analysis? This is sort of another level of specificity. It uses geographic information systems to identify locations in a given geography where there's an imbalance between the needs of the population and the resources. So I'm going to say that over and over and over again. Spatial gap analysis or any kind of gap analysis is simply looking at, you know, what's the total number of people who need something and what are the total number of resources available in a given place to meet those needs. And as I was saying, you can think about this on a global level. So maybe you think about the totality of your county or the totality of California, or you think about it at the individual level. I've worked in states where they've looked at individual children and families who needed a particular service, and they've measured specifically for those individuals whether they have good access or not. And really, ultimately, what this requires is some kind of data on resources, right? The supply of a particular service, and some kind of data on assessed needs. And we can do this in a whole bunch of different ways, from simple to complex. And what I really wanted to do here today was just show you sort of two ways that this has been done. And there are lots of other ways to do it. But essentially, as long as you have some way to look at needs, and I think we've covered a lot of that, Wendy and I did in the tertiary, secondary, and primary part. There's lots of data sources on what might be needed somewhere. The next part is resources. So where are these things that supply or that address the needs we've identified? Next slide, please. So I'll start with a county level example from Maine. So as part of their implementation of FFPSA, the Maine legislature mandated that they provide an update on how they were addressing service gaps. And this posed a particular problem in that they had not done any kind of gap analysis as part of their approved 5-year plan. So they only had about a year to do it, which wasn't a ton of time. So they knew they were going to have to use existing data sources. They weren't going to have time to do surveys. They weren't going to have time to do a lot of data collection. They had to work with what they had. And so they had 3 specifically identified interventions in their plan, and they're listed here. And they had a pretty good idea based on contracts, which is one place to start. You go through your contracts and try and find out where providers are located, although that can be tricky because what we discovered in Maine, as I've discovered in other places, is sometimes that address is where the bills go, but not necessarily where the services are provided. So that required a little bit of work on their part to sort of tease that out. But in the end, what they decided to do was leverage their state 211. And I'll talk a little bit more about what 211s are and how they work in a bit. But that made things work much faster, in part because 211s have a pretty good set of data on the actual delivery locations of services. And so by using the 211 data and their contracts data, they were able to do some good work around figuring out where services actually were. And this ultimately is going to help them differentiate by county on their contracting process going forward. Next slide, please. So the first thing they did is they went into their administrative database, their CWIS system, and they pulled out some data around the number of service cases that they had that their assessments led them to believe needed the MMT or MAT services. So you can see they looked at some case trends over time. They looked at it by county. They looked at prevalence and total numbers or rates. And this helped them get a feel for where their data was. And it also formed the basis for where there was need, at least at the county level. Next map, please, or next slide, please. And it is a map. So what they were able to do is every one of these counties, right, is the data on the previous slide. So they were able to say, okay, in a given county, we know based on our internal administrative data that last year there were this many MMT or MAT cases, or cases that could have benefited from that intervention. And what they wanted to know is where there were providers. And so they wanted to look at the zip code level, although with 211, we could have easily looked at the actual street address and sort of matched the two up. And so this is an example of a fairly straightforward gap analysis. They can get much more complex than this, but in this case, we simply geocoded the addresses. And you could even use a Google map for this. Google Map has the ability to take a database of addresses and render it as points. It even has the ability to put values on counties like this. So you don't even need a lot of specialized software to do it. And you can see here, they were able to find places where there were not a lot of cases, but there was a lot of resources. And there were other places where there were not a lot of resources and a lot of cases. So this allowed them to start thinking strategically about the next year. How can we build capacity where we need it? And why is it that we're contracting for resources where we may or may not actually need them? Next slide, please. So I mentioned it before, but I'll talk a little bit more about 211 because it was so useful in Maine. We're starting to see it get used other places as well. Next slide, please. So 211 is part of United Way Worldwide's featured programs, and they're operated all over the country. United Way likes to say about 95% of the population of the United States is covered by a 211. And essentially it's a number, right? It's a call center. All of them are usually local in some way, whether that's a state 211 or a county's 211. They have a lot of primary information or information on local human services, and they're a call center. You call them up, you tell them what you need, and they help you find the services that are local to you. They take calls, texts, web search. Next slide, please. But what's really great about them, and I think that goes unknown, is there are these 211 counts websites. So for 42 states, I think that's the number, it changes all the time. You can look up a dashboard that looks just like this. So this is California's 211 counts dashboard. And so this is showing all the service requests from August 10th, 2021, to August 9th, 2022. And you can even change the dates. You can go as far back as, I think Maine's, we had almost 10 years of data we could look at just on the counts dashboard. The little map below is zip codes. You can click on any zip code and it'll tell you things like poverty rates, unemployment rates, high school diploma, rental housing. It'll tell you how many requests they had in the last year. It gives you a population number so you can do a rate. You can see on this one, housing and shelter is 31% of their requests in the last year. And in the bottom corner, that's a graph on mental health and addiction requests, and you can compare year-over-year trends. It's amazing how far you can drill down on this dashboard. In Maine, we got a data sharing request with the local 211 in about 6 weeks, and we got the raw data behind this, and it is incredibly detailed. They use various taxonomies from place to place, but you can get down to the very specific program type of intervention and use that data to make some really good comparisons. So this dashboard really gives you the need part of your gap analysis. Next slide, please. Now, what's great is this might be the more familiar way people are used to using 211. This is how you find services. So a lot of these services, a lot of these sites, you can search by type, mental health, substance abuse, you can search by name, and you can see this is a map of Sacramento, and we're looking at behavioral health services, and you get exact street addresses. So you know where these providers are. And so in Maine, what we did is we searched right through the website for places that had MMT or MAT. And then we just pulled those addresses right off the website, built a spreadsheet, double checked it with their contracts. And in a couple of weeks, we had what we thought was a fairly comprehensive list of MMT and MAT providers in the state. We knew it wasn't perfect, but given the amount of time we had, we felt like it was a pretty good estimation of what was there. In California, there are 3 big 211s. So there's this one, the California 211, which covers everything except for San Diego and Los Angeles County. They have their own separate 211s. They don't, unfortunately, have 211 counts websites. You'd probably have to contact them separately about what data they have that you can share. But for everywhere else in California, you've got a nice set of data that will provide you with a good sense of need, and a good sense of supply. Next slide, please. So another example is sort of a global example. So rather than looking specifically at where are there specific populations, like in Maine, like where are all the MMT and MAT, New York wanted to get a sense of whether or not they had big groups in their prevention continuum, and a little bit of how those groups varied from place to place. So New York City had really good assessment data. They had a lot of it over multiple years, and that was evidence that they used to inform a lot of their decision-making in their system. So we were able to look at a sample of, a little over 2,600 low-risk preventive cases. And the question we wanted to ask was, are there groups within those 2,600 cases that have similar characteristics and similar needs? Can we group them together in ways that would allow us to design services that would specifically serve groups that looked alike? And what we used was something called latent class analysis. It's a fairly standard statistical analysis program. And I know it takes a little bit of knowledge of statistics to use it, but it's not too complicated and doesn't require really intense levels of data to make it work. And what we wanted to do is just ask the LCA, look at all these cases and tell us if there's groups. Next slide, please. And so here's what it found. A little bit of it got cut off on the bottom, but there's each one of these lines represents a group, and on the bottom there are characteristics like high parent deficits, low parent deficits. And basically what the LCA did, it said, hey, those 2,600 cases, there's really just 3 groups within this. And there's one class, which are high parent deficits and low parent and child strengths. So about 10% of that 2,600, so 260 cases, the assessments told them they had a group that had these characteristics. About half of all of those 2,600 cases were low parent deficits and low concrete needs and moderate parent and child strengths. And then the final group, about 40%, were high parent and child strengths. So what was interesting about this was the number of parents and children in this preventative case that really had high deficits and low child strengths was very small. They actually had a great deal of families in that 2,600 that probably could have been helped with more of a primary prevention service array than actually becoming involved with New York City's Administration for Children's Services. So right out of the gate, that helped them think more about how do we start pushing services upstream to primary so that we don't have as many families as we do in secondary. And then the next question was, well, we do seem to have this group of high parent deficits and low parent and child strengths. What can we learn about that specific set of families to build a service array that intensively identifies and addresses their needs? Because it seemed like they were the most likely to end up entering foster care. Next slide, please. So then they wanted to look by borough how these things sort of vary around. And what you can see is in almost every borough, the majority of cases were in this class 2, low deficits and low concrete needs, but moderate parent and child strengths. But you can see that the class that was perhaps most concerning, class 1, had a fair amount of variability. So for example, in Staten Island, there were very few cases that came out of Staten Island that fit that category. So that might tell you that you don't need as much of it as an intensive approach there as you might need in other places, whereas Queens had the highest proportion. So this is just an example of how you might use assessment data, if you have it, to try and find groups, naturally forming groups that will allow you to build strategies to address their needs. Next slide, please. Oh, I think I'm handing it off. Richard?
Yeah, so we will be handing it over here shortly to talk about the integrated core practice model. Hold on. So we're gonna address a few. We are gonna take the time to address a few questions, and somebody should come off mute and tell me if we're not going to do that. Okay, so here are some questions that are related to sort of what you've heard so far. it's sort of fresh in your minds. All right. So the one question, I'm going to stop sharing for a bit, is the CDSS requirement for the CPP one broad, back to the question we asked before, one broad theory of change related to the entirety of the prevention plan, or for each strategy in the prevention plan?
So hi, everybody. This is Kelly Winston with CDSS, and so I'm here to help answer those questions for us. So our thinking on that was really that we're looking at one broad theory of change. The idea is that we want you to take a look at your population, identify your gaps in services, and really connect your theory of change to that analysis. I think if that's helpful for you to determine, who are the populations you're going to serve and where the need is most met, and how to use all of the funding to do all of that, then I think that makes the most sense.
Thanks, Kelly. Next question. The California 5-year plan draft issued 4/22/22 under components or requirements of the CPP states a theory of change or a logic model. Do we have to do both?
No, in fact, that section of the draft plan is taken from the all-county letter 2223 for the FFPS state block grant, and only one of those is required. You do not have to do both. We wanted to provide some flexibility.
All right, next question. At the tertiary level, candidacy populations can only be selected from these categories as defined in the FFPSA prevention plan?
So the 10 categories listed in the prevention plan are what we think are likely examples of candidate pools that we think you're going to see when you do an assessment for imminent risk. So if you think about it that way, we tried to come up with those candidate pools in order to help folks better understand who their likely population to serve would be. This is the potential universe of candidates that you may serve. The chances of you serving all of them are really slim. Maybe someday, and that's certainly the direction and the hope that we want to achieve, but they're examples of who you can serve. The idea is that there may be circumstances outside of those 10 candidate pools that still meet that imminent risk criteria, and providing that you can describe those characteristics and circumstances that would imply eligibility, but those are hard to measure, right? So the 10 candidacy pools are there to help you better understand your population.
And Kelly, it strikes me that there, while we said in that slide, if you remember that Wendy presented with the Venn diagrams, it doesn't mean that you can't use the state block grant to provide tertiary services that aren't eligible for FFPSA. It just, it perhaps is not the most strategic use of the state block grant if 4E will pay for it, right? But it doesn't mean you can't.
Yeah, that's very correct.
Next question. Does CDSS have a definition for homeless and runaway youth that we have to use for defining candidacy? So I presume, Kelly, the question means, there's a HUD definition, and then McKinney-Vento has a definition. There might be some other definitions.
Right. No, there's no definition that we included in the plan that is a requirement. Obviously, those definitions that you just cited, Kush, may help you determine what you want to describe as homeless. And I think, when you're thinking about how you work with your collaborative, you may be using different definitions, and you want to have a conversation about how to come up with some sort of common ground so that you're measuring the same population. One additional thing I would add is that we do have ACL 1516 that describes, and I just said that backwards, ACL 1615 that describes CDSS's definition of a youth missing from care. So something to look at. Again, it's not a requirement, but some ways in which you may describe your population you're trying to measure.
Great, thank you. And, this is, these views don't necessarily represent those of the network. I'm about to qualify but if I were your consultant and you asked me, should you do a theory of change or a logic model? I would tell you, well, I would tell you to do a logic model if you were going to pick one, because that's going to help you implement, right? The theory of change is implied in the logic model, but if you had to pick, if I were your consultant, I'd be telling you to do the logic model. Is the theory of change easier to do? Absolutely. But then you're going to have to do something to decide for planning how you're going to deploy that theory of change. So a logic model is a great way to do that. So what's going to get you to implementation faster? A logic model. All right. Well, I don't have any further questions. Thank you so much, Kelly. We are going to move to the next part of our presentation with Richard and Integrated Core Practice Model. Welcome, Richard. Here we go.
Hey, Kush. Thanks a bunch. Gosh, what a rich conversation this morning. I have learned so many things in terms of where to go with thinking around comprehensive prevention planning. This has been just a fantastic conversation. What we'd like to do is spend another 25, 30 minutes or so with you contemplating on the kind of connective supports that are envisioned when the state invites the integrated core practice model to be a part of your planning process. So feel free, Kush, to go ahead and advance us one slide. And while we're going to talk a little bit about potential strategies, those are kind of implicit in this. So, and I'll talk more about that in a second or two in terms of how the ICPM informs and supports, or can inform and support your work. Next slide. So we lifted here as a starting place a quick quotation from, I think, either the March letter on CP planning or some related informational document, but you can see that the state really does see an opportunity, and I think it's a worthy one, to recognize how the essential content of the practice model, particularly the values, principles, and behaviors that comprise the integrated core practice model, can support and are necessary to support a comprehensive planning process, and ultimately the planning services the prevention services that you deliver. What's important to recognize, and we're going to try to hit these two things here as major goals in the next 30 minutes. Just want to pause for a second and reflect that the clinical research on therapeutic interventions in general, kind of regardless of where they originate, all lead us back to this kind of universal recognition that success or clinical effect is contingent on the relational trust that is present between a participant and a provider. Now, I don't think there's any argument for that. It's true in a school classroom, it's true at your grocery store, it's true at your auto dealer, right? Like, you go to people you trust to get what you need, and the same is true in our world. And so the integrated core practice model foundationally contains the essential ingredients to deepen, to create and foster that kind of clinical relationality. So in two ways then, the integrated core practice model is going to influence your CPP work. It's going to drive potentially enhanced planning during the developmental phases that we're all in right now. And then once you have a program, a service, a continuum of prevention supports in place, the practice behaviors at that practitioner level, the teaming engagement, the provider level, that's where it's going to impact long term. So there's kind of this twofold recognition, I think, if you will, where ICPM is going to support the work. Next slide. By way of some context, then, effectiveness is going to be enhanced by your capacity to build on the ICPM work you've done underneath your system of care work. And ultimately, when we talk about getting to overrepresentation and addressing longstanding disproportionality, the very essence of that invites a focus on effectiveness and particularly moving power within the relationship we have with those that are in care. And so to do that effectively, again, ICPM is a go-to source. More contextual to the planning process, the systemic level, if you will, no one agency can plan or execute a comprehensive prevention plan. You can't do it in a vacuum. We've talked about that in prior webinar settings. And so the ICPM, again, is designed to support the collaboration and teaming, which are obvious and explicit within ICPM for both programming and service delivery, practically speaking, as well as the fiscal budgeting, which was the topic of our conversation a few weeks back. And then finally, by way of context, a good continuum of prevention is inherently trauma-informed. If we can get kids services well in advance prior to having to impact one of the system partners, then we've effectively done our work. Next slide. All right. A little more context then specific to the CPP work. The social services that are available to us within the partnership dynamic that's inherent within the system of care MOU really demands that we be in a highly integrated environment. If we're going to be able to access our partner services as part of our CPP work, it may not be part of your FFPSA Part 1 prescriptive part, right? But in a broader context, those interagency leadership team relationships are critical. And this is all, this is one of the primary drivers. This opportunity of Family First Prevention Services planning and CPP planning is one of the primary drivers for which the integrated core practice model is one of your 11 MOU components within your system of care partnership. So let's take a look at the next slide and note here, for those of you that are a little less familiar with the system of care work, your system of care partners under AB 2083 have a memorandum of agreement or understanding in place that has at least 11 components. And I've highlighted here in either teal or more foundational to ICPM itself in number 5, the elements of the memorandum that really can be and hopefully are in place in your jurisdiction to support this kind of complex planning process that we're engaged in here. So just anchoring in, again, further context that the foresight of your system of care work hopefully has positioned you in a place where you are maximally ready to build on and do the gaps analysis, the data work, and ultimately craft a thoughtful and effective prevention plan. Next slide. And really just restating then these bullets here on the right-hand side, the processes and the domains, some of the domains that you have to attend to as an integrated planning process, the needs determination, the planning reporting, ultimately your long-term accountabilities for compliance, the data, the fiscal dynamics, all of that stuff, and ultimately with a goal of impacting access and equity and fairness are anchored in interagency relationships. Just restating again and again that you cannot do this with one modality or one department alone. And so ICPM is the kind of book of scripture where you can be linked, if you will, across this spectrum. And over on the left, this slide looks familiar to, if you were with us in our prior conversation, we used it to highlight the parallel prevention work that's happening that can be leveraged. It's within those parallel worlds where prevention work is happening or will be happening that you can leverage the data, leverage the fiscal sophistication, right? So again, anchoring that it's ICPM that will get us here over the long haul. Next slide, Kush. If you're a visual processor like me, just tried to call out here that if we're looking for comprehensive prevention plan effectiveness, if the highest rung on these 3 steps is the objective, then we really need two things in place into which you can anchor and around which you can anchor your CPP planning process. You've got to have a system of care relationship amongst partners in your MOU that allows you to have these kind of planful conversations and where you can share data and information and coordinate care. And you need an integrated core practice model that gives us the behaviors to do that work. So both of these steps are necessary, and they are departure points for any good implementation work, if you will. Next slide. Let's orient a little bit to the integrated core practice model. It was released in 2018. It's been out in communities now for a little over 4 years. And the intentionality, of course, is to provide a framework that outlines how services are developed and delivered and to support implementation of practice statewide. So you can see this language that's now 4 years old applies in your prevention continuum planning process. And the related goal, of course, is the intentionality to facilitate a common framework, set of strategies that integrates the essential elements of a good engagement and service delivery process: the planning, the delivery, the coordination, the monitoring, the transition work, and we'll talk a little bit more about that as time allows, between systems, because again, your CPP process is a multi-stakeholder, multi-agency, cross-sector a service delivery process. Next slide. A quick refresh on the principles of the system of care as they're found within your MOU, and that these are also the center of any effective prevention continuum. Most of you are probably familiar with family engagement research, right? The principles on the left here are almost synonymous with the foundational principles of any good community-based prevention approach or modality, if you will. So we're speaking the same language, regardless of kind of how you look at your prevention process. So just a quick refresh on the system of care values. Let's talk for a second in the next slide about the adaptation of integrated core practice model. We are, and some of you are aware of this, in the late stages of updating the 2018 integrated core practice model. The state's begun its active review of the document that some of you have helped us inform. In the last, although it started a number of years ago, it was pre-pandemic, and we took a long, deep breath on this process during the pandemic, like we did in so many other areas. But the integrated core practice model, when it was released in 2018, found enough interest amongst many of our partners beyond welfare and beyond mental health that folks came forward and said, you know, how can that integrated core practice model apply in my work? And among those numerous audiences were our intellectual developmental disabilities service sector, so our regional center professionals, our community-based providers who find themselves on the front lines of prevention through family resource center work, our current and former foster youth who said, you know what, we see a voice for ourselves more affirmatively in ICPM, can we talk about that? We've had conversations with biological parents and with others with lived experience at the caregiver level. We've engaged STRTP, short-term residential treatment program, and foster family agency providers and resource families. We had a vibrant conversation over many months with both general and special education experts around the state, and just concluded earlier this year a really in-depth conversation with tribal and native service experts around how ICPM crosswalks to the ICWA research and the ICWA standards and expectations under the Indian Child Welfare Act. So we've had, in other words, a very comprehensive effort underway over a number of years now to identify where the state's selected practice model, ICPM, will impact potentially and support this idea of therapeutic effectiveness and system integration both in parallel ways across the full spectrum of care. And so by having a comprehensive prevention planning process in place, we're effectively expanding the continuum, right? We're pushing way upstream. And so the supports, documentation framework for how we approach that work must also expand, and ICPM will be in position to do that in 2022. Next slide, thanks Kush, highlights some of the enhancements, and we're super excited about some of these and can hardly wait for the field to see these, but we've added language in and around the conversation to support racial equity, fairness, and this whole idea of impacting disproportionality and overrepresentation. You'll see language in ICPM 2022 later this fall, we hope, that reflects the value and need to engage early, to offer resources supports through a truly preventative lens. So specific to what we're all engaged in here in terms of comprehensive prevention planning, the ICPM will have language in it in a number of places, and what we think are critical places to help build that connectivity to your prevention partners and to the prevention field, if you will. Again, we have the voice of lived experience, which will be far more inclusive and declarative in ICPM 2022. We talked about the tribal emphasis. You'll see significant added value in that area. Same with community-based provider organizations. And what one of the more exciting things that personally that is pretty invigorating to me is we've spent a number of months with some folks who kind of live and operate in this the neuroscience, neurodiversity world. And what you're going to see is some just really groundbreaking content in ICPM 2022 that supports the way we relate to each other moment to moment and in a teaming environment. When it's done with high awareness, we are all in a position of high relational and emotional intelligence, which is where the therapeutic alliance is built and maintains itself, right? So that we don't rupture our healing relationships under stress. And ultimately, care is far more effective when we do that. So think Brene Brown, right? And what we've done is we've tried to bake Brene Brown into ICPM, if you will. That's an overstatement, but that's really the intent. Let's see. Go ahead, Kush, and push us forward. If you're so to summarize all of that and the kind of structural intent of the ICPM 2022, it is to maintain this kind of common language and establish the shared theoretical concepts, principles, values, and behaviors for all of the service sectors, right? So not just probation, welfare, and mental health, who were the kind of target audiences or the focal audiences, if you will, of ICPM 2018 and previous versions to core practice, but to all of these service sectors, because this is where so much of the prevention work is already happening or will be happening. Next slide. So let's ponder for just a moment on this idea that engagement is the critical and predictive index to all modalities, whether you are practicing PCIT, parent-child interactive therapy, or parents as teachers, or any of the approved modalities, doesn't matter. Every single one of them, the universal truth is the success of that is contingent on the professional's ability to establish an engagement with the participants, right? The clients, if you will. And then departing from that and building upon that, how do we effectively assess needs and strengths? How do we engage them in a planning conversation? How do we monitor that plan for effectiveness? And then how do we transition into and beyond the next care episode? And so think of prevention. So when you think about prevention, this 5-step process that's inherent within most practice models, and certainly California's ICPM, you see the imperative that we be mindful about these 5 phases or elements of care and how the practice behaviors support each one of those going forward. Next slide. So let's spend a minute or two in reflection on how the leadership behaviors of the integrated core practice model can support your cross-sector interagency comprehensive prevention planning process. In a developmental adaptive planning process, particularly one that's stressful like we're in now, right? Because we have workforce issues, we've got a clock that's ticking on your plan submission. There are other stressors in your work environments, probably too many to name, right? It demands that we have a high communication capacity in and between organizations and within your own organization. So communication, job one, right, of senior leaders and managers under a planning process, the clarity, the consistency, and the frequency of that communication is essential. And ICPM leadership behaviors provide you this fantastic set of references for how I should be as an engaged interagency manager or leader. The ICPM leadership behaviors foster a client of us, right? Of oneness, of integrity across the system, rather than placing us in a position where we're going to blame and shame our partners as we plan. We're going to create this climate of we're in it together, and that the swim lanes are less important, right? Because we're trying to do a comprehensive prevention plan. We've talked already about the engagement behaviors that are fostered at the practice level within ICPM, and we won't do that in any great detail today, but most of you are familiar with ICPM's practice behaviors and how those can relate. We will talk about leadership behaviors in some detail here in a couple of minutes. And there are other factors, of course, to good leadership that are supported by ICPM, including your teams having clear, dedicated resourced roles, both in planning and in service delivery, and that there be interagency feedback loops. This is where your interagency leadership team comes in terms of how it will support across the spectrum the planning process, if you will. All right. Let's go ahead and advance that. So with all that in mind, then, let's just spend a minute or two with some examples lifted from the integrated core practice model around in at least 4 of the domains of the integrated core practice model that can effectively support your planning process. So I'm going to give you a moment or two to reflect on these just quietly. The first 2 come from the engagement and then the inquiry exploration portions of the leadership components of ICPM, and just invite you to reflect quietly, and then we'll ponder a little bit more on this. You can see in both the engagement and the inquiry exploration, the curiosity domain, if you will, as I sometimes like to call it, you can see the language that supports behavior that will foster an effective planning process by and between leaders. In other words, doing these kinds of things build and deepen the engagement and leave us open, inquisitive to the process and to a partner's needs, so that we can come up with the most effective plan possible. Next slide has teaming and accountability behaviors. So I'm going to give you a moment or two to reflect on these. You can see that these, again, provide us resources for how we should be. And I use that word be intentionally, right? How do we act? How do we behave with one another and with our community partners who are so critical to our prevention continuum successes? So again, engagement area, inquiry area, teaming area, accountability area, the ICPM leadership behaviors are explicitly in place to support the very kinds of processes that are intended within the CPP planning process. Next slide. All of the ICPM leadership behaviors invite us into this place where we're operating at a high degree of emotional intelligence, right? And the relational wealth for us as partners in a system planning process is high. And this is among my favorite slides because you can really distill integrated core practice model leadership behaviors into these kind of 5 or 6 things. When we can effectively practice high uncertainty or embracing not knowing, we are open to the data, open to the information, open to the feedback, open to the needs of our partners, right? When we suspend judgment continually, we'll find the capacity with our partners to meet those needs and to not make assumptions or judgments based in past performance or in whatever beliefs we bring to the planning conversation about ourselves or others. When we seek first to understand, then be understood, again, we're creating this open planning environment, right, into which community partners, the voices of lived experience, and numerous others that are involved are going to be, will be critical. When we invite and act on feedback honestly, with authenticity, we're demonstrating the kind of accountability that ICPM seeks to support and the kind of accountability that leads to high trust and ultimately to good planning process. Holding lightly to our own stories is another way of suggesting that we leave our minds open to the truths of others, right? That multiple perspectives can be true at the same time, even though they compete sometimes. And being able to bridge those moments when sometimes we get locked into insistence about what needs to be or what is, or what I need or what my department needs or what my community needs. If we can suspend that and just don't cling too much to our own truths, we leave ourselves in this wonderful position where collaboration is far more possible and far more likely. And when we do inquire, of course, the last one is to do so with appreciation for the intentionality of others, recognizing that that 99 times out of 100, no one's out to get us. They're out to just help us, right? So acknowledging the inquiry with based on appreciation is powerful. Next slide. Wanted to spend a moment or two just reflecting on the power of ICPM to support interagency trauma-based planning. And I want to credit our good friends at Trauma Transformed in the Bay Area for the development of these graphics and the concepts here, but they apply in almost every sector. And as you think about prevention and the extension of public programs into community like never before, then we got to be mindful of this stuff. So most of us live, historically at least, in organizations on the left side of the spectrum that are kind of trauma organized, right? Particularly in an environment where we know based on research that we ourselves as professionals are probably more vulnerable than the population at large to trauma, right? We know this from long-standing child welfare research at least, and I think it's true in the mental health world too, right? Like most of us and our peers have experienced trauma. And that's partly what makes us powerful as healers or potential healers, and it also leaves us vulnerable. It leaves us vulnerable, and we become then in collective, if we're not mindful and aware and well supported, we become then part of organizations that are reactive. We're stuck in cycles where we relive and retell our trauma and the trauma of the organization, right? We get into cycles where we're kind of numbed and avoidant. And then ultimately we are fragmented, right, by those aspects. And we lock ourselves into us and them because that's safer, right? And ultimately in places where we find ourselves in places where we can't be in a collective environment. So we have disequity, inequity, and those are often characterized by highly authoritative leadership practices, right? The safety of my own distress invites me into heavy-handedness. So I'm going to be a telling authoritator, not a collaborative facilitator in terms of how I wield my authoritative power. A trauma-informed community in the center part of this spectrum is a step in the right direction, right? Acknowledging that trauma happens at the client level, it happens to staff, it happens within organizations, and that we have to understand ultimately the nature and impact of trauma and how recovery is fostered within our organizations. And of course, recognizing that there are socio-cultural impacts to and causes of trauma that happen to almost everyone we touch in the course of our day. When we're mindful about that and we have the right supports and practices in place, we then find ourselves moving deliberately, willfully to the right-hand side of this spectrum, where we are far more likely to be in healing organizations. And if you've ever had that experience, and hopefully it's a part of your occupational journey at some point, the difference between the trauma organized or reactive organization and one that's reflective it's palpable, right? And it's our job to build those kinds of organizations where we can live with reflection rather than reaction, where we can collectively and in partnership make meaning out of the past and learn from it so that we don't just recycle through it, right? Where we are growth and prevention oriented, where we're highly collaborative. And with those things in place, then we can really address things like equity, access, fairness, social justice, right? We have to be in these balanced organizations so that we can be in a position of impact, right? All of that demands of us really relational leadership, which is what ICPM seeks to foster. Again, it's about a high emotional intelligence, high relational wealth bank that allows us to be open, accessible to each other. Next slide. As we kind of wind down and support here, I have some of the questions and the issues that I think are going to come up around how then more practically, right? Because ICPM is largely conceptual in much of its narrative prose. Only in the leadership behaviors and the practice behaviors do we get to this place of concreteness in ICPM. It's like the last 15 pages, right, of the document, those of you who know it and are familiar with it. So I want to try to make this as concrete as I can. So some of the things I would be thinking about is, have I cross-trained amongst my planning partners, at least, to ICPM? Do we all have, as much as possible, a collective awareness about what it is and how we're going to try to walk the walk of core practice? I would be in a place trying to put myself in a place where I would recognize and celebrate effective teaming at every turn, right? It's within that celebratory approach to teaming, not just child and family teaming, right? I'm talking about teaming in all of its forms, including the teams we bring together to plan, that we can begin to move power and share power effectively, and ultimately get to this question of inclusion, right? And real diversity, if you will. I would be looking for places to link in my kind of brainstorming, at least around CPP planning, looking for places to link the screening and assessment processes that are going to be required into your system of care front door, right? So really concretely here, what do my red teams look like in my child protective services functionality that could potentially expand to effectively link the services and the information needed to navigate candidacy versus foster care, right? We're going to have kids who are going to live in that spectrum. Not every kid that comes in as a candidate is going to stay a candidate. Some kids are going to become foster kids, right? And you also have care and services and supports within your prevention continuum that if you applied them to kids in foster care might move more quickly out of foster care back into a community-based setting, right? So there's this dynamism to the continuum that really invites us into thinking, how do we take our existing processes, and these are not just welfare, so I've got red teams on here, right? But it's also in mental health, like if I have an access line and a front door in mental health, how do I connect to that, right? Because if I can do that concretely for kids as kids or caregivers as they reach out for services or as they're identified as candidates, I'm going to be far better endowed. My continuum is richer, better positioned to keep them as candidates, right? And keep them out of deep end services, which is the foundational goal. I would add prevention and comprehensive prevention planning into my next revision of my MOU. I know a couple counties are beginning to think about revising their system of care memoranda of understanding. So look for places, we talked about this a couple weeks ago, look for places where you can add in concrete language to how you're going to build on your CPP and prevention work under FFPSA. There's one question on here that I purposely left off. It's this question of, back to the start of this, to my component here, which is how do I put ICPM content, or how does ICPM inform my plan process? And the reason I didn't want to address that concretely here is that the answer is that it's unique based upon your county's perspective, right? And how you have approached ICPM implementation going forward in the last 2 or 3 years, right? So there's no one answer. It's very training centric, which is why you've heard training be an emphasis, not just from me, but from others today. If I were responsible for a planning articulation, if I were writing the narrative, the prose part of my CPP plan, I would be prepared to narrate in there aspects of how integrated core practice model fostered our teaming process for planning. Like, how did we incorporate the behaviors and the interagency leadership team in our planning process, right? And then secondarily, and I think to the state's intent around inviting us to do ICPM-based CPP work, how will the modalities we select for our plan that will be funded with our continuum of dollars, how will those processes be informed by the foundational engagement, assessment, service delivery, the monitoring, and the transitions? Again, right? Those 5 domains or phases of ICPM. Look for ways to put that language into your CPP plan. I hope that makes sense. Ultimately, if I'm looking back at some of Jennifer's rich content this morning around logic modeling, within that logic model framework, there are activating processes, right? Steps. It's largely in that component of my logic modeling where I think I would expect to see integrated core practice model based actions or approaches, if you will, if that makes sense. So ICPM, I would want to see ICPM in that logic model at that point. All right. I think that might be my next last slide. Yeah, I think I'm good. Kush, I will yield back to you at this point.
Yeah, Richard, thank you so much. I mean, I can see, and I actually hadn't seen before until I heard you talk today, that, you know, any and we talked about this in the governance when we talked about governance a couple of learning forums ago, where you need to have a team that's going to govern the planning and the implementation of prevention services. And that team's going to have either an MOU or some sort of other document that charters it. And those leadership behaviors, the leadership roles, the factors of emotional intelligence can all be part of that document. You know, any good chartering document has guiding principles in it. right? So these can be those. So inside of your description of your governance structure, these can fit in really, really well.
Oh, yeah.
There's a question about when ICPM 2022 will be available, Richard.
Yeah, in 2022, that's the answer. What we anticipate is that when we have a release on this fall, I'll say loosely this fall, you're going to see an ICPM that's not just led by and authored, if you will, blessed by healthcare services and social services, which are the two obligations, the two departments that are obligated underneath the KDA, right? ICPM is a legacy to KDA, the state's practice model underneath that settlement. What you're going to see in 2022 is an integrated core practice model that is signed off on and blessed by, and I hope with an introductory page with signatures from developmental services, Tony Thurmond at education, social services, Department of Rehab, Department of Healthcare Services, and social services. So you'll see all the partners signing off on this document. And again, I want to say fall, let's say end of October, I hope.
Got it. Thank you, Richard, very much. And thank you to all of our presenters. You know, I was sharing with them when we were doing our rehearsals that, you know, they have day jobs, and you know, taking the time to think about material, send it in, taking feedback to curate it. It's a fair bit of work, and we really appreciate it. So we do have time for some more questions. We are going to have a Q&A session on that's related to this particular learning forum on August 31st. And at some point you will get the registration link to that if you have not already. And so I just wanted to mention that. And then let's move to some of our questions. All right. So, hold on, folks, give me a moment. Okay, is there a quick link to the 10 candidacy groups?
I don't know if it's a quick link, Kush, but certainly it's available. I can drop into the chat the last draft of the prevention plan that was shared with stakeholders in April. And it's in the section on child and family eligibility. So if you search for that terminology, you should be able to find the 10 candidate pools.
Thank you. Next question. Has the state finalized a template for the CPP?
Sorry about that, had problems getting off mute there. So we haven't finalized the template just yet. We are aiming for that to be released with our website that will house the Comprehensive Prevention Plan Toolkit. We want to be able to roll tools out as they are ready so that folks aren't waiting for the whole thing before it gets released. And so we're thinking the template is going to be available sometime in early September.
And Kelly, am I right that they don't have to use that template per se? That they could, as long as the elements of the block grant letter, ACL 2223, I believe, are reflected, they can use any format, kind of similarly to how we address the plan with Administration for Children and Families, which is, well, we got the elements, but we're not necessarily going to use your format or sequence.
That's absolutely correct. The template is available for your convenience. If you choose to use it, that's great. If you choose to have a different format, that's also fine.
All right. So next question. Any updates on the readiness assessment? So there isn't, and this is also reflected in the block grant letter, there isn't one readiness assessment required for developing your CPP or then future implementation of that CPP. And it's not mandatory that you do one. Okay. That said, we are developing an implementation guide that are based on the same readiness domains that this learning series is based on. And there will be an associated, you could say it's a checklist, right, that reflects that guide for those folks that like checklists, right? Did we do this element? Did we do that element? Did we check, would you select our tool for this section? So those are in development. And as a teaser for the 8:31 Q&A session, we are still on track to be able to give you a sneak preview of that implementation guide and what associated tools might in the future, like Kelly was reflecting, be linked to that implementation guide. We certainly won't have all the tools linked by then, but we do plan on giving you a sneak preview of the implementation guide. Okay, so there's that one. Next question. Do we know when the plan is being sent back to the Administration for Children and Families?
That's also a great question. So we are in the process of finalizing our next draft, or actually what we hope will be our final draft. It's about to go through our executive review and then up through agency. So we've got a few weeks of review and incorporation of feedback there. The goal for submitting to ACF is scheduled for the end of September. And we're hoping to meet that date. Working really hard for that.
Thanks, Kelly. This is a question for Richard. Would you suggest we include cross-training on ICPM to our implementation team partners as part of our CPP?
So I think that's one way to view the value of the integrated core practice model. What I would offer, I guess, is that the ultimate reason for cross-training or interagency training to ICPM is to deepen the effectiveness of your practice, right, across your system of care. All partners, regardless of their modalities or programs, right? It applies everywhere. So do it for that reason. And then as part of your CPP plan, you can articulate, we have trained to ICPM, right? We have implemented on some level integrated core practice model, and it's affecting, or we anticipate it will affect our prevention continuum in this way. So don't cross-train solely because you feel it's going to enhance your CPP plan. Cross-train because it's the right thing to do across your entire continuum, right?
Yeah, thank you, Richard. Next question. Will the state have a required template or format for data reporting, fidelity monitoring, and outcome reporting?
I don't know that I would call it a required format, but we do anticipate incorporating, monitoring of outcomes in our CQI process. And so we're further developing what we have outlined in the prevention plan draft already, and we'll be probably coming to all of you in the near future to talk about what that will look like. There will definitely be opportunities for input into that process. And really right now we're anticipating that any data collected to do that work will be incorporated into the automation of that program. So definitely more to come on that.
And while you have the floor, Kelly, do you want to just say something about the orientation, and then we can drop a link for folks on
Yeah. Absolutely. So there is an orientation that we'll be offering for counties who are interested in learning more about the options for support that are available. It includes wonderful presentations like you're here experiencing today, as well as some of the other opportunities for support that we have through the state. That is scheduled for the afternoon of the 23rd. Stephanie just put the link for registration in the chat. So we hope to see you there.
Great. And then I think this one is for you, Kelly. Also, do you know what will happen if, for whatever reason, ACF does not approve our plan?
So similar to the process we experienced last time we submitted the plan, they came back and asked us some questions. I would assume that if for some reason it's not approvable as is, we'll go through the same kind of iterative communication with them. Now, having said that, we've had some communication with them about what they're expecting to see in this second iteration of the plan. We've worked with a lot of other organizations, including Cape and Hall, who have a lot of access to what other states have experienced in their review process. And so we believe we have strong changes to the plan that will be acceptable. And then if anything, the tweaks that we need to make might be minor.
Thank you so much, Kelly.
Mhm.
All right. I think those are the questions we're going to answer today. And I am going to turn it over to Caltrin to bring us home. And let me share my screen.
Yeah. Well, I just want to say on behalf of the participants today, just thank you to all the panelists and all the speakers for all the information and the valuable examples that you brought with you. Want to give you a couple reminders to those that are with us still. The first is that we will, and Kush talked about this, there's a Q&A session on August the 31st. Highly encourage you to register for that event. So with that, we want to say thank you so much for attending today, and we look forward to seeing you in future sessions.
Then I will say goodbye for now, and we'll see hopefully many of you on the 31st and at future learning forums. Have a great rest of the week, and we'll see you soon.